Hello, and welcome to Breast Cancer Conversations, a podcast brought to you by survivingbreastcancer.org. I'm Laura Carfang, breast cancer survivor and founder of survivingbreastcancer.org, a nonprofit organization providing community, education, and resources to empower those diagnosed with breast cancer and their caregivers from day one and beyond. Hello, my friends, and welcome to another episode of Breast Cancer Conversations. Welcome back if you are an avid listener. Welcome today if it's your first time tuning in. I'm so glad you are here. As you heard in our intro, survivingbreastcancer.org produces our podcast, Breast Cancer Conversations. And I want you to know that in addition to our podcast, especially if you're new to the station, especially if you're new to our channel, is that we also have a variety of virtual programming that you have access to 100% free. So if you want to jump on over to survivingbreastcancer.org/events, you will find everything from virtual weekly support groups for those of all stages, including early stage, metastatic, and inflammatory breast cancer. We have expressive writing, art therapy classes. We have weekly meditations, yoga, Pilates, on-demand content like Qigong, forest bathing, hypnosis. Yes, virtual hypnosis is a thing for pain management in the cancer community, plus so much more, all free and available to you. So check out survivingbreastcancer.org/events to never miss a beat and get engaged with our community. All right, turning things over back to why you are actually here today, which is our podcast. In today's episode, I am especially grateful to bring to you because it tackles a diagnosis that often sounds reassuring on paper, but feels anything but simple in real life. DCIS, or ductal carcinoma in situ. Often referred to as stage 0 breast cancer, DCIS has an excellent prognosis. And yet, the decisions that follow about surgery, radiation, hormone therapy, and long-term risk can feel overwhelming, confusing, and deeply personal. This conversation is about how those decisions are made when there isn't one right answer, and how science, clinical experience, and patient values all come together at a point of care. I'm joined today by an extraordinary multidisciplinary panel of women who are helping shape how DCIS is diagnosed, treated, and discussed. Dr. Erica Giblin, a breast surgical oncologist in Indianapolis and director of breast surgical oncology at Ascension, brings a surgeon's perspective on balancing effective treatment with long-term survivorship. Dr. Fleur Gallant is a nationally recognized leader in breast radiation oncology and radiation medicine leader for the breast disease management team at Northwell Health Cancer Institute. Her work focuses on delivering high-quality, personalized care to her patients with a focus on quality of life. I am also joined with a dear friend who I met in the advocacy breast cancer space, Dr. Laura Carfang. She is the Vice President of Global Medical Affairs at Prelude DX, a board-certified physician associate with decades of experience in internal medicine and oncology diagnostics. She is an 11-year stage 3 breast cancer survivor who brings the patient voice into every scientific conversation. Together, we break down what DCIS actually is, why staging can be confusing, how radiation decisions are evolving, and how genomic tools like DecisionRT are helping patients and clinicians move away from a one-size-fits-all care towards treatment decisions rooted in evidence, clarity, and personal values. Welcome to the conversation.
Hi, everybody. Laura Carfang. I'm the VP of Medical Affairs at Prelude DX. I run our patient advocacy, and I'm an 11-year stage 3 breast cancer survivor.
So my name is Fleur Gallant. I'm a radiation oncologist. I specialize in breast radiation oncology. I've been practicing in New York for over 11 years, really dedicated to breast cancer as a subspecialty. I definitely have come to cancer from a personal place. I actually had been studying music originally, and then my mom was diagnosed with stage 4 cancer and passed very quickly after, and that kind of led me towards medicine. And then right after I finished my boards in the US and started practicing, my sister was diagnosed with breast cancer. So cancer is definitely something very near and dear to my heart. And I've been feel very fortunate to be working with breast cancer patients. I want to thank you for all the work that you do, which is really amazing, supporting all the patients and survivors. And I just should say too that, just as a disclosure, I actually am a speaker for Prelude because I do work with Prelude. I'm a big fan of the DecisionRT test. I use it a lot in practice, and I have done talks for them. So I just wanted to put that out there as well.
Erica Giblin. I am a breast surgical oncologist, so breast cancer surgeon, and I am based here in Indianapolis. Cold and not hot in Tampa or like where Leona's at. So I'm very jealous right now.
Oh, I know. We can live vicariously with the warm weather. So when we think about DCIS, so someone fill me in.
So in situ, inside the breast, underneath the skin, you have a bunch of pipes, a bunch of tubes. And those tubes go all over the place. They sort of interconnect like a spider web. Okay, so it's like a big spider web of pipes in there. And those are basically hoses. It's a bunch of hoses to basically get the milk to the nipple. That's the goal of it. So what can happen is sometimes the hose, which is called a duct, has a lining. Okay, so if you look down the middle of the hose, you see the lining of it. And the lining is composed of these little things called cells. Okay, they're like little blocks and they should all look the same. So what can happen is one of the little blocks can form a cancer cell inside that lining. And that cancer cell can make a bunch of baby cancer cells that start to clog up the inside of the lining, and then they start to move along the inside of the pipe. And a lot of times when they're moving along the inside of the pipe, the lining of the pipe gets irritated and it lays down little calcium pellets. So you'll see that on a mammogram, little white dots. That's calcifications. Now, a lot of people think, a lot of patients think that the calcifications on the mammogram are the cancer. They're little breadcrumbs saying where the pipes are all chock full of cancer cells. So DCIS is cancer cells stuck inside the duct milk pipe.
Appreciate you acknowledging that there's cancer cells, so like malignant cells that are cancerous within that pipe, within that duct.
Yeah, I think that was a great visual description. Something that I mention to patients too, because there is confusion about what is a non-invasive cancer. Is it a precancer? And it's actually not a precancer. It is considered a real breast cancer, but it is a non-invasive breast cancer. So it's a cancer that does, those little cancer cells inside the pipes do not have the knowledge or the ability to spread outside of those ducts. So it really, DCIS in and of itself, it stays in the ducts, it's non-invasive, it can't hurt you. The only reason we even care about DCIS is because it does have the potential to become an invasive malignant cancer. And I sometimes mention too, there's something called LCIS, which is the lobular version of DCIS, because, like was previously said, there's ducts that bring the milk, but the lobules, the lobes, are what create the milk. And you can get LCIS, and we see this all the time. We think of LCIS as a marker for an increased risk of breast cancer, but we don't treat it. We don't give radiation for it because we don't think that it becomes an invasive cancer. So it is confusing terminology, but the bottom line is it's a non-invasive breast cancer. It has an excellent prognosis. And the only reason we really care about it is because we don't want it to turn into an invasive cancer.
After that great description and visualization of, where this cancer is starting and coming from, how does the staging work for that?
Well, so for breast cancer, you have 4 stages. Now, what is confusing is the first stage is 0. And that probably sort of doesn't make sense to a lot of people. Like, what does 0 mean? So remember, the cancer cells are stuck inside the pipes. Okay? They're not busting out of the pipes. And as Dr. Gallant said, once the cancer cell pops out of that pipe, we call that invasive ductal cancer. So for the DCIS, once again, cancer cells in situ inside the pipe, it actually doesn't matter how big it is. Okay, it could be tiny, 1 millimeter. It could be 10 centimeters of that stuff in the breast, but it's stuck in pipes. We call that stage 0. What's great about that is survival is pretty much like 99.99%. So it's close to 100, as a physician can tell a patient. We start assigning actual numbers like stage 1, stage 2, stage 3, stage 4 to patients where the cancer has busted out of the pipes. Okay, so stage 1's busted out of the pipe, certain size. And then we start to get towards stage 2, stage 3, where it's invasive and it's moving. Okay, it's moving to the lymph nodes. And then finally, stage 4, it's moved throughout the body. So that's just a gestalt on the staging system.
I can already think we run a support group at survivingbreastcancer.org every Thursday, and there are women who attend with stage 0 DCIS. And there is always confusion of, what do you mean stage 0? Do you have cancer? Do you not have cancer? And we use this as an educational opportunity to speak about it. But then we also don't want to dismiss or undermine that you didn't get out unscarred. Like you got diagnosed with cancer, which is a very traumatic word to hear, regardless of what stage you're in. And so I know there's always, it's never like who had the worst treatment or the best treatment or any of that thing, right? I think even as women, we get very competitive, but when it comes down to cancer, it's just like, oh gosh, we're all here to support each other, and everyone's experience and opportunities for types of treatment really come down to like the personalization of the characteristics of the tumor, the patient's decisions and choices, the shared decision making with their doctors and oncology team. So I would love to hear, before we jump into the work that Prelude is doing, what's the current practice right now when a patient gets diagnosed with DCIS?
Normally, when breast cancer patients come in, usually the first person they see is the surgeon. With cancer care, I sort of think of it like Goldilocks and the Three Bears. Okay, you don't want to do too little. I don't want to do too much. I want to figure out what's right, for the patient. And it's individualized. Each patient, their cancer is like a fingerprint. It's unique to them. Its biology is unique to them. The conundrum with DCIS and calling something stage 0, right? The survival's great, right? Dr. Gallant said, cancer cells are stuck in the pipe. As long as they don't bust out, it's not going to kill you. Okay, you can go the rest of your life. The hard part about it is trying to figure out which patients have cancer that's never going to bust out of the pipes, right? And then which patients have cancer cells in the pipes that are maybe more active. Those guys just have a different biology, a little bit more aggressive behavior. And those guys want to bust out of the pipe. And if they bust out of the pipe, that causes invasive cancer, which if not untreated is a threat to life, right? So how do we get really specific in terms of what patients need? Because nobody wants to go get surgery and radiation and pills that they got to take if maybe they don't have to. Right? So trying to do the less is more approach, as long as it's equivalent, it works out to good survival. So for years, we had a cookbook, okay, the way they were supposed to do stuff. So a surgeon goes in and we got to get the DCIS out as long as it's small enough in comparison to the breast size. So breast size does matter. Small breast sometimes is a little bit bigger deal in terms of getting stuff out. But if we can get the cancer out with a lump, okay, so that's called lumpectomy, and make sure the edges are clear. The edges got to be clear. That's called a margin. It's like a fence line. The cancer can't touch the fence line because that means the surgeon got it all out. Okay, so that's getting it out. But with cancer care, even stage 0, we have to determine, do we have to add layers of armor to the breast, layers of protection to make sure the cancer doesn't come back, even if it's a stage 0 that wants to have a little bit more punch and be invasive. That's where the DecisionRT test was a game changer, at least for me and my patients, quite honestly. Because before, I'd have to say, let's get the lump out. You got to go get radiation. Dr. Gallant can talk about like how long and how many doses you'd have to get. And then we got to give you a hormone blocking pill if your cancer is fed by your hormones, right? So the Prelude company came out with a test called DecisionRT. That test was a game changer, right? Because now we're able to see through doors we couldn't see through before. We're able to have information to let us know who has a DCIS that wants to maybe be a little bit more, have a little more punch and try to become an invasive cancer. Maybe radiation does do a lot of benefit for those people versus those who their DCIS is sleepy. It doesn't really do anything. Maybe they can get away without doing radiation. So that's what
I appreciate that. Thanks for giving us that overview too of the first steps and when a patient gets diagnosed, who do they see to make some of these decisions, especially when they are stage 0. So Dr. Gallant, can I ask you then, when do you get involved and see patients and help them navigate these choices?
Yeah, so it usually is after the surgery, although sometimes if a patient is trying to make up their mind as to what treatment approach they want, sometimes I'll see them before just to help them make up their mind. Because usually, just like similar to a stage 1 breast cancer, there's really 2 options that are considered to be equivalent. You can have a lumpectomy with radiation, or you can have a mastectomy. And in terms of the risk of the cancer coming back in the breast, both are considered absolutely equivalent. And that's the stage for stage 0. It's the case for stage 1. And, a lot of times it comes down to personal preference. Sometimes it comes down to whether or not a patient is a good candidate for a lumpectomy. Sometimes a patient might not be a great candidate for radiation. There's certain, things like having autoimmune disease, like lupus, that can actually increase a patient's sensitivity to radiation, or certain genetic disorders. So, sometimes a surgeon, if they have a concern about the patient's ability to have radiation safely, they'll send them, in advance to see if they're a good candidate. Those situations are pretty rare, but we do see them. But sometimes a patient just is like, I don't know if I want a mastectomy, or I don't know if I want, a lumpectomy and radiation. And in order to make a fully informed consent, they come to see me to hear all the details about the radiation so that they can make up their mind. A lot of patients know right off the bat, I definitely don't want to lose my breast. It's very important for me to keep my breast. Sometimes they'll go straight to lumpectomy, and then I see them after. But as was touched on, it really is sort of the quote unquote standard that, you have a DCIS, you get a lumpectomy, and then we give radiation. And it's not that we haven't tried as radiation oncologists in the past to find a select subgroup of patients that we could avoid radiation. There's been many trials looking at, well, maybe not all of these stage 0 breast cancer patients really need radiation, because radiation is well tolerated, but you don't want to give it for nothing. There are side effects during the radiation. There's long-term side effects, including some serious ones. So we don't want to, we don't take it lightly. So maybe in our patients that have smaller DCIS or low-grade DCIS, maybe patients who are older, maybe we can avoid the radiation. And they've done several trials looking at that. And even in the patients where we think, okay, it looks small, it looks, like the features are favorable, let's not give these patients radiation. Well, the patients still benefited from the radiation. So they kind of weren't able to find a group of low risk patients who couldn't still benefit from radiation. The radiation always brought that risk lower. We were kind of back at the point where, well, if you have a lumpectomy for DCIS, you're getting the radiation. And that's where the DecisionRT test has come in and has helped us to go beyond what we're getting back on the pathology report, like in terms of how big it was, what the grade was. Were there other features like necrosis, which are, just different descriptions of what the pathologist looks at when they look at the specimen under the microscope. So the DecisionRT gives us more detailed information and actually can tell us, is this patient going to benefit from radiation or not? So it's helping us to go beyond what, those features that we used to have and really determine who benefits from the radiation. And I would just like to make a quick comment too about your point about, the stage 0 patients maybe feeling like, they don't have as serious of a cancer compared to some of the stage 1 or stage 2. And what I often say to my residents and colleagues, sometimes the longest consultations I have are with my DCIS patients. And it's in a way a good thing because DCIS patients have an excellent prognosis, so they have a lot of different options. But having all of those options can be stressful and confusing. And some people just want to be told by the doctor, like, just tell me what to do. And I don't want to, like, you're the expert. But sometimes we have to say, you do have these different options. And, these are the pros and cons of option A, and these are the pros and cons of option B. And then that does put some onus and stress on to the patient to make those decisions. So I definitely, feel for a lot of these patients, many of whom are young as well.
Absolutely. And thanks for acknowledging that. Dr. Hemrick, I want to ask you from a patient perspective, and congratulations on 7 years of survivorship. And I know you mentioned that you were stage 3, so not necessarily DCIS, but tell me a little bit about your experience, and did you end up having radiation?
Okay. Yeah. So I'll try to keep it short. It's a big story, but I was 38, so I was too young for mammograms, and it wasn't palpable. So it wasn't anything I would have found on a self-breast exam. I actually saw a spot in my armpit and kind of suggested my own mammogram, since I'm in healthcare. So that led to the diagnosis. At the time, we had no idea it would be so advanced. So my surgeon here in Tampa ordered MammoPrint, which is another one of these type of tests that you can use on invasive cancers to try to determine a benefit from chemotherapy, right? A lot like Oncotype, which people have heard of. So I go through all of these things. I wake up from surgery to then find out that it was stage 3. I had the full axillary dissection, so I have no lymph nodes in my right arm at all. Everything's been taken out. And that meant I had to do chemotherapy. So I had to go through the red devil chemo that people know and hear about. And after all of that, they did want to radiate me. They wanted to radiate my axilla, and I wouldn't do it. I just said no. Sorry, Dr. Kawan. But it's enough. I've had enough. So that was my decision. My MammoPrint score came back low. It's not indicated for a tumor as advanced as mine, but I hedged my bets that was a good sign, that it came back was a low biological risk. I did try the hormone therapies that are often recommended. I made it about 6 months. I had to take the aromatase inhibitors, which are the next gen, right? Not the tamoxifen that some women know. I have a genetic mutation, so I couldn't take that drug. And the side effects were so bad. At 39 years old, I was seeing a medical oncologist that's a friend of mine. And we're still friends. We text pretty often. In front of my mother, he looked at me and said, "If you don't take this drug, you're going to die." And I said, "Well, I'd rather be dead." And that was the end of that conversation. I don't think he would say that now. I think he's learned a lot in 11 years. But I said, if it's that important to you, then let's do a hysterectomy. If you want to turn off my estrogen, cut it out because I can't take these drugs. So then I also had a hysterectomy. So it was about 18 months of a long and complicated journey for me. I'll tell you that back then and now, I was just looking at my mammogram print yesterday. It was relevant to a conversation I was having with a physician. I clutch those results. It's very important to me. And it's helped me lay my head on the pillow at night to have my information on my tumor and have a better understanding of my biology.
Yeah. Thank you for sharing that. And I know a lot of our listeners can resonate with, whether you're diagnosed early stage with stage 0 and having to navigate the complex decision making of I have all of these choices. And I'm so grateful and I feel lucky that it was caught at stage 0 and I have such great survival rates and outcomes. But at the same time, it's very overwhelming a lot of times learning a different language. And then to your example, Leona, understanding that when do you decide quality of life over treatment? And obviously, we have standards of care and we want people to stay on their treatment as long as possible. And how do we ease a lot of these side effects that we're experiencing? And then also, to use your phrase, like, hedging your bets, right? You're like, at some point, you know your body and you're like, you know what, this is the choice I'm making. And I tell people all the time, and this is advice I give myself, is like when I can look at myself in the mirror in the morning, knowing that I made the best decision for me, I'm at peace. And that's the best decision. Everyone's going to have an opinion. Trust me about that one. But if you can wake up in the morning and say, you know what, I feel confident about the decision I made and I have no regrets, then you're in good space there.
Yeah, Leona, thank you for sharing that. I've known you for so long now, but I never heard all the details of that story. So thank you for sharing. And I want to say too, like, obviously, as medical professionals, it's our duty to advise patients on, what we recommend based on evidence. If the evidence is not as strong, it's our duty to explain that to the patient as well. And at the end of the day, it is shared decision making. I mean, that's a very trendy word right now in breast cancer, but it's a very important, thing to keep in mind. I mean, it's up to us to advise these are the benefits, these are the risks, and it's up to the patient to make the decision if those benefits are worth the risk to them. And at the end of the day, as I tell my patients, you're the boss. Like, I'm going to make recommendations. If I feel like you're making a choice that's really, really, not in your best interest, I will do my best to try to convince you. But at the end of the day, as long as you have informed decision making, it's our role to respect the choice of the patient.
Absolutely.
I think that's key. It's find often that women make decisions out of fear, and that really hurts my heart. If they can make decisions out of information, I have no problem. If a woman with DCIS says, I want a mastectomy, and she's made that decision from an educated place, and that helps her lay her head on the pillow at night, then I support that. If the decision's made out of fear or anxiety, that bothers me. So I like to see women making informed decisions. And that's why I love these kind of conversations with amazing surgeons like Dr. Giblin and radiation oncologists like Dr. Gallant that will help provide that information and help women make decisions. And the only other thing I want to say, the way I talk about it is the only small trauma is someone else's trauma. So when you're going through that cancer, stage 0 is just as serious as stage 3. It's yours. It's your experience, and it's still the big C.
So tell me a little bit about, let's fast forward. So we know typically what the treatments are, what has happened. We understand what DCIS is, what it is not, how it operates, what the treatment options are. When did DecisionRT come onto the scene?
DecisionRT has been on the market now for several years, about 9 years that we've been on the market. And we're used widely at a lot of institutions. A randomized controlled trial will be starting in just a couple of months that's sponsored by the NRG, so one of the cooperative groups that helps to develop studies to really just flush out all of the details, of whatever the diagnostic test or drug happens to be. DecisionRT is looking at a few different proteins that are in that tumor. So you're taking the actual biology of the tumor and then combining that with clinical pathological features. And it provides you a score. And there, I think, was a misconception early on a few years ago that the score was black or white, that it was either treat or no treat. And that's not at all what DecisionRT does. You know, a pregnancy test, that's black or white, right? You can't be a little bit pregnant, but you can get a little bit of radiation. So this score goes from 0 to 10. And as the score goes up, so does your risk of having a recurrence or your benefit of radiation, right? We can answer both of those questions, but not every patient is the same. So when Dr. Gallant would have a discussion with 2 patients with a score of 6, it may sound very different based on other factors. So you don't treat a piece of paper, you treat a patient, but it's good to look at the biology of the tumor when you're having those conversations.
And similar to what we were talking about with different patients and their priorities and you know what's important to them, you can have 2 patients with the exact same tumor, the exact same clinical features, the exact same score, and one patient will look at the benefit of radiation and say like, "No, you want me to do, you know, all that treatment with all those side effects you talked about for like a 5 or 10% benefit? Like, thanks, but no thanks. I'm comfortable with having a slightly higher risk." Someone else will want the radiation, even if it's just a 1 or 2% benefit. They don't want to leave any stone unturned. Their priority is to make sure this cancer doesn't come back. So it's, you know, like Leona said, it's a combination of disease factors, patient factors, the score. And yeah, at the end of the day, it's what is important to the patient.
And when you're talking about the like tumor characteristics and like biology, are you referring to like the hormonal status and like receptors of progesterone, estrogen, HER2?
Progesterone is in there directly. So we do measure PR, but there's things in there that are not things you would normally think of. One is called FOXA1, and that happens to be a protein that is the gatekeeper for estrogen. So if you don't have that receptor working properly, it really doesn't matter what the estrogen status is because you have to have the pathway, the biological pathway. So it's very complicated science, but it actually looks at different pathways that would allow cancers to develop and grow, and then weights those with all of the fancy computers and artificial intelligence and things that we don't have the ability to do to provide those scores.
Absolutely. Thank you for that. And Dr. Giblin, when do you currently use DecisionRT and bring it up with your patients as one of your tests?
I pretty much order at all of my DCS patients.
You do? Okay. Yeah. So tell me, yes, when did you get exposed to it and how did you start utilizing it? And can you tell me a little bit about how that's changed, like your practice and conversations you have with patients?
It's changed the conversations remarkably. So Dr. Gallant actually gave an example of a patient. She said some patients might have really tiny DCIS, might be millimeters, right? And they will ask the question, why do I need radiation? And the radiation doc may say, man, that's small. Look like it's good. You know, maybe we don't need radiation. But this test helps us, once again, figure out which DCISs are more aggressive, right? Even though that patient has a super tiny DCIS, that thing might have a little firepower. So radiation is needed as an added layer of protection. So I think that opens the eyes of not only the doctors, but also the patients. So I've been using this for years. I saw it at a meeting and I was like, this looks really cool. It looks like a game changer. I'm going to give it a whirl. And when I did that, it helped my patients a lot. That's the whole reason we're doing this, is for patient care. I have a lot of patients that come in. I think Dr. Glau and Dr. Hamrick said they're terrified. It doesn't matter that it's stage 0. It doesn't matter if the survival's great. They have cancer, right? It's word to hit them. And they will say a lot of times out of fear, I don't want surgery. I don't want radiation. It's the head in the sand, right? The ostrich head in the sand, because they're so scared. They don't know what to do. So they don't want to do anything. It's a pullback, right? So scared they want to just try to run, okay? Fight or flight. And when you talk to them about this test and how it can help us determine what do we exactly have to do to make sure we cure their cancer, that really sits true with them. And not only that, the test is easy to interpret, not only for the doctor, but for the patient. Because when you get the results back, it gives you number score. And the number score looks at over the next 10 years, right? Next decade. What is the risk that if I just take a lump out, that the DCIS is going to come back? If it's just with taking the lump out. And not only that, what is the risk that it's going to try to be invasive, not just DCIS? Then it gives you another score, which is what is the percent that it will come back if we add radiation? Okay. Now, I saw a patient today. She had DCIS. We had DecisionRT on her. And it came back over 10 years. If I take a lump out, her risk of this stuff coming back is 4%. It's pretty darn low. Then you look at the category below, which is if we had radiation, the risk was 4%. There was 0% difference. Doesn't matter if I had it's not changing the game. It's not helping her. So this gives her a choice, additional information to make a choice. She thinks 0% benefit is still worth getting radiation. Maybe she does. And if she does, that's fine. If she doesn't, we have data to support her decision not to get radiation. I had a patient last week. Her DCS was tiny. We ran a DecisionRT on it. If I take a lump out, her risk of cancer coming back over the next 10 years was 42%. Had radiation, that dropped down to 10%. That really rung true with her. She's like, I should go get radiation. So this just gives patients more of finite, detailed information to have them digest, to help them make decisions instead of just the doctor sitting there saying, you should do this, you should do that, based on these statistics and that statistics. This is real numbers based on their DCIS, like a fingerprint, once again, given to them. I think that's remarkable.
Absolutely. Yeah, I can't agree more. And in terms of my journey through using DCIS or DecisionRT for DCIS patients, we were pretty early users of the platform. And initially, at the time, the amount of data to support the test was more limited. So I was using it a little bit more cautiously. So a lot of times I would see a patient where I thought they would be able to avoid radiation, and I would do the test just to make sure that, it wasn't like a wolf in sheep's clothing, so to speak. I wanted to make sure, everything about this tumor looks low risk. I don't want to give radiation. Let's get the test to make sure. But then as the data to support the test grew and grew, and my confidence grew and grew, and then I would start using it and realize, oh yeah, this is a patient that I didn't think needed radiation and she does. And here's a patient now that, I think needs radiation and she doesn't. It started changing my recommendations so much that I also started using it pretty much uniformly in all of my patients. Occasionally, I'll see patients who, will they'll tell me there's no way I'm doing radiation no matter what you tell me. I'm not going to order a test if they know they're not going to do radiation no matter what. Although I've even had patients who have said I don't want radiation, and they were really young and I was really worried about them, and I ordered the test and it came back high risk, and then that was enough to convince her to do the radiation. So sometimes even in patients who are telling you they're not going to do radiation, seeing the test results can sway them. And yeah, so we've participated both at my prior institution, Maimonides, and here at my current institution in Northwell. We've been participating in the PREDICT trials, PREDICT 1 and PREDICT 2, which basically looks at how the DecisionRT test will change management, both from the patient's perspective and from the physician's perspective. And it's very exciting too, now that as Dr. Hamrick mentioned, we have a NRG trial, a randomized phase trial, which is going to be sort of the gold standard of, evidence to support the tool. And in terms of some people who are not so keen on use, like sometimes certain physicians will push back and say, well, why are you using this test? Because it doesn't have that gold standard randomized controlled trial level of evidence. And what I mentioned to people is, of course, we all want the best quality evidence, but I have a patient in front of me here today who needs to decide what they're doing. And they don't maybe want to wait around for the next 10 to 15 years to get that result. And what the DecisionRT has done, Prelude, they've actually taken a randomized control trial, which is the SWE DCIS trial. So that was a randomized control trial where patients were randomized to radiation, no radiation, and they followed those patients over time and saw how they did. So Prelude actually took those tumor samples and sort of retrospectively, prospectively evaluated those patients and were able to give more support that this test really has been consistent amongst various different patient populations. So I do have enough, confidence in the test that I feel even before getting those randomized results that I can still recommend it.
Yeah, you're seeing firsthand evidence in your clinic when you're talking to your patients, like you're seeing the applicability of it, which is really great to hear. I was in the same boat with you, Dr. Hedrick. I had lymph node involvement. So, chemotherapy, radiation, like everything was, you just get it all, right? And so I don't want to say I didn't have a choice, but, the literature and everything suggests that I should really go through with radiation. So I can see this, though, for people who are kind of on the fence and really just trying to understand what their options are and weighing the risk of what at the end of the day is important to them. Because, and, we could do a whole episode on, survivorship and, hitting these great milestones. I'm approaching my 10 years of survivorship.
Congrats.
And, I wanted to let my listeners know too, because we're talking, and Dr. Galib, I was hearing you also mention what is your 10-year risk? And so let's run this test and kind of see what that 10-year risk is. 10 years can feel so long. I might be moving. I'm going to have a different career. Who even knows what's going to happen 10 years from now? And someone who was on hormonal therapies for 8 years, I never thought I was going to see the end of that journey. And then here now approaching 10, time does continue. And, you're always living in the back of your head with this idea of, is the cancer coming back? Is it recurring? You want to get to this milestone. You don't want the shoe to drop. Did I do enough? And so, these are real conversations, but I'm actually really excited, Dr. Hemrick and I, that you and I can both be here showing hope and inspiration for our listeners too, that, 10 years plus later, we're here thriving. So I appreciate that.
And actually, one thing I'd like to mention specifically, since you brought up young breast cancer patients, is that something that radiation oncologists will most typically do is the younger a patient is with DCIS, the more likely they are to recommend the radiation. And a lot of the trials do show that age is one of the strongest prognostic factors. So younger patients tend to have higher risks of recurrence compared to older patients. But we know both in the invasive and in the DCIS worlds that the tumor doesn't always know that it's in a 30-year-old or an 80-year-old. We see really aggressive tumors in 80-year-olds and really indolent, non-aggressive tumors in young patients. But, prior to having DecisionRT, I would pretty much, without fail, be recommending radiation therapy to anybody under the age of 50. And that's really the way I was trained. And I do still know some physicians who take that approach. They just don't feel comfortable taking a risk in a younger patient. But from my point of view, yes, we don't want a young patient to have a recurrence, especially not an invasive recurrence. But I also worry the most about my younger patients in terms of their quality of life and the amount of time that they have left in their lifetime to deal with the side effects. And although the long-term side effects of radiation, most of them are cosmetic, cause scarring in the breast. It can cause the breast to become firmer and smaller. If there ever is a need for future surgeries, it can complicate, having any future surgeries down the line. So from a quality of life point of view, the way the breast looks and feels can be really important, especially to a younger patient. And then there's also an extremely rare, but still potentially serious risk of the radiation itself causing damage to a normal healthy cell that can then lead to a future cancer, usually a minimum of 10, 15 years down the line. Thankfully, these are extremely, extremely rare. I just happened to see one today who was, after 11 years of being in practice, I saw someone who did have a radiation-related cancer. And this is one of our most devastating types of fears, that, we could actually harm somebody with the cancer that is a lot more aggressive than the cancer that they had that we treated them for. So from my perspective, thinking about younger patients, I also do, love the DecisionRT test, because sometimes I look at a patient and it's small and, they were just really good about getting their mammograms done because of family history. And we found this thing and it was so small. And then we get a low risk DecisionRT score that reassures me this was not a bad DCIS. This is probably a DCIS that was never going to progress into anything that would hurt the patient. I feel really, happy, and the patients are very happy that we don't have to bring out the big guns with the radiation.
Sure. One question that's still outstanding, Dr. Hemrick, you made the example that the way that this test comes back with the results is not necessarily yes and no, black and white, the way other tests can be. So I want to talk a little bit about how those results can then change and shape the conversation about how much radiation to give. I was definitely one of those candidates that had 30 days, Monday through Friday, 30 rounds, et cetera. That accumulative effect of, the burning, the uncomfortableness, the fatigue, et cetera. So I would just love to hear if there have been examples where people have been able to reduce the duration of chemotherapy or the potency, or how does that work, if I can learn a little bit more?
Sure. So there's been a lot of change over the past decade in radiation therapy regimens. It sounds like the regimen that you got would be sort of what we would call conventional radiation, where you're taking the dose that we know we need to give to be effective at preventing the cancer from coming back. But you can't give that dose all at once. it would be too toxic, and it would really hurt you if we gave all of that radiation all in one shot. So what we do is we take that dose and we break it up into what we call fractions, which is just daily treatments, Monday through Friday, 5 days a week. And the most typical daily dose is 2 gray per day. And typically you're getting, 25 to 30 treatments over 5 to 6 weeks. And over time, there have been many countries like Canada, where I'm from, also the UK, they were saying, this is really inconvenient. It's taking a long time to deliver radiation. Maybe we can give slightly bigger doses and shorten the time. So instead of giving, that 2 gray per day, maybe we'll do 2.6 gray per day. And we can take what the same radiation that we're giving in 5 weeks, now we're condensing it into 3 weeks. And they did trials on this with, breast radiation therapy after lumpectomy. They found that it was more convenient, just as effective, and actually a little bit better in terms of the long-term side effects and side effects during treatment. So that became kind of the standard for when we're just giving radiation to the breast. Now we have evidence saying even if you're getting radiation to the breast and the lymph nodes or after mastectomy, you can still do that 3 weeks of radiation. So today, if you were to get treated, you probably would have had a shorter course. And then finally, this is more pertinent for patients, with DCIS. You can give whole breast radiation therapy or now partial breast radiation in 5 days. So there, we're taking that same dose we know that we need to be effective, but we're giving bigger doses over 5 treatments. And because the technology has changed so much and advanced so much, we're able to be much more targeted and specific in terms of the way we deliver the radiation, so we can do this safely. And essentially, if you have a lumpectomy, you could get 5 days of radiation and be done, or potentially have 5 days of partial breast radiation. And partial breast, not everybody is a candidate for partial breast radiation, but for those who are, it's a great treatment because you're only treating the area where the lumpectomy was and a certain margin around that. So if you're someone that has a relatively small lumpectomy cavity and a larger breast, we can spare a lot of the normal breast tissue and just treat the involved area. And these patients have also been shown in well-designed trials to have just as good of outcomes as giving whole breast radiation. So lots of options now. And another reason why some of these discussions can be so complicated with patients.
Yep, thanks for that overview. I just got back from the San Antonio Breast Cancer Symposium this December and was like, oh my gosh, I wish I had all of these options when I was going through treatment. Like, these are getting so much better. So shout out for all the clinical trials that are taking place for people who are really moving the needle in how we're treating breast cancer.
The one thing that I would say is that women need to be their own advocate, right? And I think that's a little bit generational, right? I think I grew up in Southern West Virginia. That's where I practiced medicine. And the older women that I would see in Appalachia would absolutely just do whatever I said. They would not ask any questions. That was just generational. I think the younger generations are better at seeking out information and going to the internet, trying to learn. But a lot of them still may not push not all the physicians are as good as Dr. Giblin and Dr. Gallant. I guess that's my point. And if you have one of those physicians that says, no, you don't need that test, we don't use that technology, I think you should push back. And that's not just about DecisionRT. It's about any of these tests, any of this molecular information that is new, cutting edge, disruptive, that we think can help. You should engage and ask about it and get more information and find where you can get it. There's going to be physicians all around the country that are doing these things, but you may have to seek them out. You may have to get a second opinion. And if it was my mom or my sister, I would push.
That's a great point. I mean, one thing that comes to mind too is just what we touched on before, which is this test is not black and white. It's not a treat versus don't treat. And I have had patients with high scores where I'm recommending the radiation and they look at that score and they're like, you know what? I'm okay with this. I know that radiation isn't going to make me live longer because it's never been shown in the trials to make someone live longer. So I'm just going to get watched really carefully. If it comes back, I'll deal with it then and I'll get radiation. On the flip side, I've had patients where they actually have a score that comes back at that very low risk score of 0.8, showing no benefit whatsoever from the radiation. But they have other features that make me uncomfortable avoiding the radiation. So I've had a young patient with a low score that had over 6 centimeters of disease, and the disease was multifocal, and some of the margins were close. I'm like, even though I have this score that's telling me you're not going to benefit from the radiation, you have enough of these other features that makes me nervous and not treating you. So at the end of the day, you have to look not just at, the DecisionRT score, but you have to look at all of the features of a particular patient to make the right decision for them.
Excellent point. Thank you for sharing that. Yeah, like the whole person, right? Like getting as much information as possible, just one piece of the story.
Mm-hmm.
Dr. Giblin, anything from your vantage point?
I think they all outlined everything very good. One thing I do, and this may be controversial, is even in patients who are choosing mastectomy, doesn't matter if they're a candidate for lumpectomy, they want a mastectomy, or sometimes the DCIS is very big. I'll run the test. And this is why. If the score comes back high, so remember I talked about that one patient where there's a 42% risk of it coming back with a lumpectomy. Well, a mastectomy is a really big lumpectomy. I mean, we're taking, quote unquote, all the breast tissue out, but all surgeons leave a little bit of normal breast tissue behind. So the reason that I do that on those mastectomy patients is not because I'm going to have them do post-mastectomy radiation therapy. It's just that if they have a DCIS that is maybe a little bit more firepower, a little more active, this might be somebody I follow a little bit more longer in survivorship. So it also helps me with survivorship. How long should I be following some of these patients? Do I do, 2 years or 5 years, or maybe, what do I want to do? So this gives perhaps me a little bit more clarity and maybe even the patient in terms of survivorship.
That's great.
And one thing I'd like to mention too, just in terms of where we're at in breast cancer treatment in general, and I think definitely this is the case for DCIS, is we're trying to personalize and de-intensify treatments when we can safely do that, but then potentially intensify treatments for patients that have higher risk disease. And there's a lot of interesting things happening right now in the DCIS world. For example, there was a trial called the COMET trial where they're looking at not even doing surgeries on DCIS. So not only are we talking about de-intensifying treatment by not doing radiation, we're at the point now where we're looking at, maybe for these really low risk DCIS, we can just carefully watch patients. Even though that trial has been resulted, I'm not seeing a lot of people doing it in practice. I think it still makes people nervous, but it speaks to the point that not all DCIS are created equal. And there are some DCIS that would probably never amount to anything. Just like if you look at prostate cancer, in men with invasive prostate cancers but are low risk, we will watch them and not even treat their cancers, which are actually invasive. So, it's not a crazy thing to think, well, in a very low risk DCIS patient, ideally with a low DecisionRT score, that would make me feel better, although that wasn't part of the trial. But, maybe we could just watch these patients very carefully and not even treat them. On the flip side, I've had a patient on the other extreme end, young patient, had a mastectomy, had a positive margin after mastectomy, got the radiation, had a DCIS recurrence, never had invasive cancer, and ultimately ended up with bone metastases. So this is what makes DCIS so challenging, is that it can be extremely indolent, or it can actually come back and with a vengeance and become an aggressive cancer. And that's really the challenge.
I've loved this conversation, the multidisciplinary approach, the different perspectives, the thought leadership that all of you are bringing with your personal experiences in the clinic with DecisionRT as patient advocates. I'm so excited to get this out to our community. Thank you so much for being here tonight and sharing your expertise with us, providing your knowledge and understandable terms. Again, going back to like our visuals and understanding what DC, and shining light on something that's very, early stage 0, but incredibly complex. So thank you all. And thank you everyone for listening to our show. I would like to acknowledge that all of the information on our podcast is from personal experiences and is not a substitute for professional medical advice. You should always contact your medical care team. If you are looking for specific topics or would like to be a guest on our show, please feel free to reach out. My email is laura@survivingbreastcancer.org. Our show is made possible by our nonprofit, survivingbreastcancer.org, and by our incredible donors like yourself. You can hop on over to survivingbreastcancer.org to sign up for our mailing list, make a donation, and explore the 400 plus programs we offer each year at survivingbreastcancer.org/events. Until next time, keep on thriving.